Hey guys, it's Dr. Lisa Shiver talking about HIV and AIDS medications, also known as heart therapy or highly active antiretroviral therapy. There is some controversy as to when a patient should begin their antiretroviral drugs, and there's no one good answer. It honestly comes down to when the patient is willing to start the medication. Just because it requires a strict routine and regimen, and some of the medicines have some nasty side effects, so you really want to have a patient who is committed to taking the drugs, because like antibiotics, if a patient doesn't take the complete regimen, then it can cause some resistance. So ultimately, when to start is determined by the patient and the physician together. The CDC recommends that when your T-cell counts are lower than 350, and just to refresh your memory, your T-cell count, the normal range runs about 600 to 1200. So when your CD4 T-cell counts get low, then that's when the recommendation is according to the CDC. But again, it does require a strict regimen. These drugs have to be taken on time, every day. They're usually on more than one medication. And there is always the issue of drug resistance. The first group we're going to look at are probably one of the more common groups that are used. They're called the reverse transcriptase inhibitors, or the RTIs. The way these drugs work is they keep the HIV virus from getting into your clean, healthy cells. So it inhibits viral replication early in the virus life cycle. So it starts early, and that's a key word here. It's going to prohibit virus replication early. It does not do anything for cells that are already infected. So these would be new infections or somebody who maybe just had an exposure. These would be the patients that would be put on an RTI. There are two different types of the RTIs, and I've got a list of the non-nucleoside reverse transcriptase inhibitors and the nucleoside here for you to look at. Don't want you to memorize them, but do look at the spelling. Well, not all, but most of the drug names here have "vir" in them, and that's a big hint that when you see a drug and you're not sure, well, what is this? Look at the spelling. Sometimes you can figure out what a drug is for by the spelling of it. In this case, antivirals are going to contain "vir" in the spelling. I've got the more common drugs, the ones we're going to focus on, highlighted in yellow, and each one of these is going to represent the rest in that same drug class. So the AZT, or the Retrovir. We're also going to talk about the Combivir, which is a combination drug, and then we'll look at the MVP, or the Verimune. We're going to start off with the AZT, also known as Retrovir. This drug is used to increase your T-cell counts, which is a good thing. Remember, your T-cells are what are looking for things it doesn't recognize, trying to protect the patient. It increases survival rates and also slows disease progression. So just to refresh, these drugs are keeping your clean cells clean. We're not letting the HIV virus get into them, so it would make sense that it would slow disease progression. We use it for the treatment of AIDS dementia. It also helps prevent infection from an HIV mom. So this is the drug that we give to pregnant HIV mamas anywhere from their second trimester throughout the remainder of their pregnancy. And then we also give it to mom when she's in labor, and we start this drug with the baby once it's born. So AZT, or Retrovir, can be used for pregnant mama during labor and then with a newborn infant. But it also can be used for any patient, so don't just think about the pregnant mom and the babies. It honestly could be used for everybody. Side effects, one of the biggest one is GI upset, and I put the price on there. You'll never be tested on that, but just to give you an idea of how much this medicine costs. With maternal therapy, pregnant mama will start her AZT, if she's willing, 14 to 34 weeks gestation, so it's going to be second trimester or later. and then continue the PO dose through the pregnancy. Once she goes into labor, then we'll put her on IV Retrovir, IV AZT. She'll get the IV medication until mom and baby are separated and the cord is clamped. With a newborn, we will give them a PO dose beginning within 12 hours after birth. The baby will be on it about 6 weeks or so. And just keep in mind, general adults, males, females, can also take this medicine by mouth, usually 3 times a day, maybe BID. Our second drug we're going to look at is the Verimune, or the MVP. This too is a reverse transcriptase inhibitor, so we're keeping the HIV virus out of the clean cells. It works a little bit different than the AZT, but they are still similar drugs. It increases your CD4 T cell counts and decreases your viral load. So we want our T cell counts to be higher. That's giving us that protection, that immunity protection. And your viral load, that's how contagious are you, so we want the viral load to be lower. These are often given with the nucleoside reverse transcriptase inhibitor, so that's your AZT group. And we always want to start this one in particular with the smallest dose possible. The reason for that is one of the nasty side effects that can occur, and that's called Stevens-Johnson syndrome. If you're given this medicine and your patient at any point in time develops any kind of rash, you must discontinue that medicine immediately. Stevens-Johnson syndrome sometimes will start with a rash that turns into blisters, that will turn into ulcers, that will cause the patient's skin basically to slough off their body, and the patient looks like a bad burn patient. But if we don't pick up on this rash in the earlier stages, the patient could develop Stevens-Johnson syndrome. If we do pick up on the rash, we could stop this from happening. So anytime you have a patient that is on Verimune or MVP or any of the non-nucleoside reverse transcriptase inhibitors, you must monitor the patient for a rash. These drugs also can cause GI upset, so that's something to keep in mind. When we're initiating the therapy, what we're going to do is do a PO dose for 14 days, and if no rash appears, then we'll increase the dose to twice a day, or BID. If a rash occurs at any point, discontinue. You can do a challenge once for these patients, and what that means is if the patient develops a rash, we're going to stop the medicine, let the rash go away, and then we could try it one more time. But if a rash appears, then the patient can no longer take this medication. So that's a re-challenge. So PO, QD for 14 days. If no rash, bump it to BID. But watch for that rash at all times. This can be given to adults, can be given to children, and just keep in mind it's usually in combination with something like AZT. And here's a picture of a patient with Stevens-Johnson syndrome. You've got the earlier stages there on the bottom right hand corner, but you see the later stages there where the skin it honestly looks like a burn patient, and some patients do not survive. There is a reverse transcriptase inhibitor combination drug called Atripla. This one has been on the market several years now, and it's 3 drugs in one. You have 1 non-nucleoside reverse transcriptase inhibitor and 2 nucleoside reverse transcriptase inhibitors. So again, we're keeping our clean cells clean. The dose is once a day, and that's what makes this unique. You have several medicines, the patient takes it once a day. Huge with compliance. They do take it at bedtime because one of the side effects there is sedation, but again, you have that GI upset as a possibility. If you ever see a rash, please discontinue that drug. I've got the cost there for you. It is a little bit higher. Patients can get federal assistance in getting their medications. The second major group we're going to look at are the protease inhibitors. These work a little bit different than the reverse transcriptase inhibitors. The protease inhibitors work late in the virus cycle. So these are more effective for somebody who maybe has a later HIV infection, or maybe somebody who has AIDS already. But what this does is it suppresses your HIV cells, or your dirty cells, from budding into more. So we're going to keep our dirty cells from making more contaminated or dirty cells. So this drug is more effective late in the virus cycle, and it actually is one of the most potent HIV drugs available. Here are some of the examples of the protease inhibitor. Please note again, you see the VIRS and the spelling for a lot of these drugs. If you're looking at a test, looking at a patient's medication, that's going to be a huge hint as to what you may be working with. The one I've picked to represent the group is the Inverase. Inverase is used to treat the advanced HIV infections and is used in combination. So when I say combination, they're probably going to be on an AZT, they may very well be on Verimune, and you're going to add the Inverase to their drug regimen. The dose is 3 times a day. One of the major side effects again is GI upset, and you're going to continue to see that with a lot of the HIV medications. And it runs about $1,000 a month roughly. Another group of antiretrovirals are the entry inhibitors, and this is a relatively new group compared to the others. You've got Fusion or T20. What this group does is it prevents the binding of HIV to cells. In other words, it keeps it from entering into the cell or fusing to the cell. So if HIV can't stick to a cell, well then it's not going to be able to get into the cell. Something that's unique about these drugs is they come in sub-Q injection form. So the patient has to do an injection, sub-Q injection, twice a day. Side effects are going to be related to localized redness or reaction. So usually that's the major issue. You don't see the GI side effects because it's a sub-Q injection. These two will be used in combination though with your reverse transcriptase inhibitors and your protease inhibitors. And it is a little costly as well. There are also integrase inhibitors or integrase strand inhibitors. You'll see them listed a couple of different ways. Acintris is the drug name. This one inhibits the enzyme that HIV needs to multiply. So if we get rid of the food that HIV needs to reproduce, well then we will stop reproduction. This one is beneficial in decreasing viral loads and increasing T cell counts, and again used in combination. They have found good results with Acintris as far as drug resistance goes, but again very costly. Some key teaching points when looking at all these drugs. Make sure you take your drugs on time. It's important for all these drugs to be taken on time so we maintain a therapeutic drug level in the system. This isn't something that you can skip a dose or adjust when you want to take it throughout the day. It has to be on a strict routine. Patients also need to be aware that this is not a cure. This isn't take it for 2 weeks and you're going to be healed. This is a long-term commitment. They also need to understand that the higher their viral load, the more contagious they are. If they are considering stopping their meds, they need to consult their doctor first. All of these drugs are not compatible with St. John's wort, and all of these drugs deactivate someone's birth control pills. If you're giving a child or an infant a suspension or a liquid medication, you give the medication, but then you also have to rinse the dose cup and let the patient drink the rinse as well. They need to get every last little drop of that medication. So when you give a liquid medicine, there's some left over. That leftover, add some water to it, and they need to drink that as well. If it's a pediatric or an infant patient who's not using a dose cup, you may need to rinse the syringe to make sure that they get every drop of that medication. Here's a little case study. You're drawing blood from a known HIV positive patient and you accidentally stick yourself with a contaminated needle. What should you do immediately? Then what are you going to do? What else will happen? What should you expect? Well, what you should do immediately is rinse or irrigate that site. If you stick your finger, go wash your hands real good with soap and water. If it's a splash exposure, eyes, mouth, you need to rinse or irrigate. That's always the first thing you're going to do. You're going to take care of yourself and clean whatever area is affected. Then what? You're going to let your supervisor know that you have had an exposure. And this is something you've got to do right away. It's not something you can wait several days to do. From there, you probably will be sent to either the ER, or you'll follow whatever your protocol is for where you're working, because you now are going to need some medical attention. If you go to the ER, we are going to draw blood on you. We're going to check a CBC. We'll probably check your chemistry panel. We're going to check you for hepatitis A and B and C. We'll do an HIV test on you. So we're going to run a bunch of tests on you as your baseline. What we're getting ready to do is, with your permission, is start you on Combivir, which was that combination reverse transcriptase inhibitor. The key here is you need to start on that within 4 hours of exposure to keep your clean cells clean. But we have to make sure that your liver's in good shape, your electrolytes are in good shape, your kidneys are okay, females are not pregnant, and we need to know what your baseline is and make sure you don't have any bloodborne disorders. So, to the ER you'll go after you wash that area immediately. You'll have your baseline test run that day, and then probably we'll have some antiretrovirals recommended, unless we know for certain that the source of those body fluids was negative. Combivir will be started. We usually have you take it for about 4 weeks or so. If we don't know the source of the splash, then you definitely will want to take that. Remember, with all these drugs, they're GI side effects, so a lot of times you'll be offered some Zofran or something like that to help ease your stomach while you're taking this medication. You also will need to consider using condoms when you have intercourse to protect your partner until you know for certain that you've not contracted HIV or anything else. Usually within 3 to 6 months we'll know for certain whether or not you've contracted HIV, but remember, the chances are super slim.